Hi guys, for those of you who don't know me, I'm Sophia. I'm going to be talking about cardiac syncope. Syncope is actually one of my least favorite chief complaints because this is the differential for syncope. There's a million causes that can cause a patient to syncopize. So since it is cardiology month, I'm just going to be talking about the cardiac causes. I'm not going to talk about the neurological ones, metabolical or toxic. And within cardiac ones, I'm just going to be talking about dysrhythmias. We're not going to be talking about vasculatures, PE, aortic dissections, stuff like that. So we're just these. So actually, up to 20% of syncope is cardiac related, and out of that 20%, 3/4 of it is just dysrhythmia. So it's actually a pretty important and significant area for syncope. So basically everybody knows what syncope is. You guys all know what to ask. You know what to look for in history. Physical exam is, unless you have a big neurological deficit or trauma, it's pretty much useless. So the two things we really need in syncope are finger stick and an EKG. So we're just going to be going over EKGs. I wanted to make it as interactive as possible. So if you guys want to, I'm going to put EKGs. You tell me what the rhythm is or what you see. I won't call on anybody. So, anybody see anything here? No? Okay. So, there's a P wave, right? P wave, P wave, P wave, drop. So, what kind of block is this? So, it's a Mobitz type 2. So, your QT here is, your PR interval is actually maintained. So it's not a wanky back, it's a type 2. You see the dropped QRS, and actually this EKG, if you look at it carefully, also has a right bundle branch block. So what about this one? Anybody? P wave? This is type 1, yeah. So this would be your wanky back, because your PR interval here is prolonged. And then you drop your QRS. Yeah, that's it, sorry. And it also has a right bundle. So your Mobitz 1 versus 2 blocks, basically, in both of them you're going to have dropped beat, but your PR interval in your Mobitz type 1 starts to become prolonged, and in your type 2 it just remains normal. So a normal PR is 0.12 seconds to 0.20, so it's 3 to 5 boxes. So if it starts changing, then you know it's type 1, and if it stays the same, it's a type 2. So anybody want to guess what this one is? 3. So this is a complete heart block. You see all your P waves, right? They're not really conducting to anything. This is a complete heart block. Basically in this one, you see P waves that are regular, but your QRS the P wave isn't conducting into a QRS. You have more P waves than QRS. Okay? This one, this one's a little tricky, but it's the same thing. It's a type 3. You have your P wave here, P wave, P wave. The regular, you have your QRS, but they're not associated. So that's a complete heart block. Also, this EKG is a little more difficult. This one has a wide complex and a slow rate, so it's a ventricular escape rhythm as well. But all right, anybody want to guess about this one? Good, WPW. You have a little bit of a wide QRS. Not all WPWs have wide QRS. You have a short PR interval, and then you have your delta wave, right? This EKG also, some people will confuse this and this. Do you know what that is? It looks like if it were a Q wave, but it's actually, when you have inversions in 3 and AVF, it's actually just the delta wave deflected downward. And some people think it's an actual Q wave, and it's called the pseudo-infarct pattern. All right, so WPW, you have your short PR. You can have a wide QRS, or you can have you can have a normal QRS. You have your delta wave. There's 3 types of WPW, type A, type B, and type C. Type A, you have your QRS is upright in all the precordials. Type B, your QRS is downward in V1 and V2. And type C, your QRS is upright in V1, V4, and then downward in V5, V6. So if you look at this one, this is a type what? It's a type A, because all your precordials are up. What about this one? So this would be a C, because it's up in V1, it's supposed to be V1 through V3, and then down in V5, V6. And then this one, the only one that's left, it's type B. It's downward in V1, V2. All right, anybody want to guess this one? I'll give a kid. Prolonged QT, good. So you're here, your QT is long. Your QT here is 0.44 to 0.48 seconds. Basically for QT prolongation, you want to make sure that you measure from the beginning of the Q wave all the way to the end of the T wave. If you have biphasic T waves, you want to measure it all the way to the end of the T wave. A good rule of thumb is if your QT is less than half of the preceding RR, if not, it's prolonged. And basically a QTC of above 5, QTCs there's apps that you can that help you calculate it because it's got like square roots and everything. If your QTC is over 500, is associated with, good, Torsad. All right, and this one, anybody want to guess what this is? Can see it here? Yeah, good, so this is Brugada. So Brugada also has 3 types. Your type 1 is you're going to have a coved ST elevation in V1, V2, followed by a T wave inversion. In type 2, you have a saddleback greater than 2 millimeter ST elevation, followed by an upright or biphasic T wave. And type 3, you have a combination of the two, but it's less than 2 millimeters. And basically these patients, if they syncopize, you want to put pads on them and you want to admit them to the CCU. So this one is what kind? So it's type 1. You see the ST elevation there. And this one would be the only one that's left. This is type 3, right? You see your ST elevation and your saddle. And then this is just the last EKG. This one wasn't really about an arrhythmia, just an FYI. Yeah, so this is right. You have your very, very large S wave in V1 and your very large P wave in V5 that shows left ventricular hypertrophy. And what are these? Yeah, those would be your dagger Q waves that are consistent with HOCM. Okay, so basically HOCM, it's doesn't always show up on EKG. It's mostly by history and family history and all that. But if you see left ventricular hypertrophy, where you take your V1 and your S wave in V1 and your R wave in V5 or V6, and if it's greater than 35 millimeters, that's left ventricular hypertrophy. And if you have your dagger-like Q waves, that can be HOCM. So basically for syncope, this is kind of the mnemonic. You want to look over Brugada, long QT, WPW, HOCM. There's other things that cause syncope, but I didn't have time for them. But those are just a couple of them. Basically, if you have like pacer malfunction, you want to call cardiology, get your pacer interrogated, SVTs, drug-induced arrhythmias, yada yada. But those were basically the main syncope EKGs that I thought everyone should kind of know. That's it. Thank you.